All participants are in a listen-only mode. After the speaker presentation, there will be a question and answer session. To ask a question during the session, you will need to press star one on your telephone. Please be advised that today's conference is being recorded. If you require any further assistance, please press star zero. I would now like to hand the conference over to your speaker today, Mr. Michael Schomer. Please go ahead, sir.
Thank you for joining us for the COVID-19 media briefing for March 23rd. Today we'll start with opening comments from Health Commissioner Jan Malcolm, State Epidemiologist Dr. Ruth Linfield, and Infectious Disease Director Chris Ersman. After that, we will open it up for questions from reporters. With that, we'll now turn it over to Commissioner Malcolm.
Thanks, Mike. Good afternoon, everyone. Well, as of today, Minnesota is at a total of 507,231 positive cases of COVID-19 since the beginning of this pandemic. That reflects an additional 855 cases reported today on a volume of 13,314 lab tests from yesterday. Both the number of cases and the number of tests are significantly lower than they were 6 days ago. Our 7-day average test positivity rate remains or is at 4.5%, which is up a couple of tenths of a percent from yesterday. While this is still in the caution range, this 4.5% test positivity is as of March 14th. We haven't talked about the lag period for a while, but just reminding folks that there is that period of time during which additional data are coming in, so that these metrics, these calculations that we report are based on a date before the lag period. And I just do want to flag that in the lag period, so after the 14th of March, we do see these numbers in terms of case growth and test positivity continuing to increase a bit. So we do go over that 5% caution range for test positivity in the lag period. So that certainly just reminds us that we are, as we've said before, at still a rather pivotal point in this pandemic where trends can change fairly quickly. Just one day after we had 0 deaths reported for the first time in a year, that we did not have a media briefing yesterday, but wanted to note the significance of that 0 deaths reported yesterday for the first time since March 24th, I believe, of 2020. Today, however, we did report an additional 7 COVID-19 deaths among Minnesotans, bringing us to a new total of 6,789 deaths since the start of the pandemic. We have 328 people currently in Minnesota hospitals being treated for COVID-19. Of those, 87 are in intensive care. At our low point for ICU use recently, we were down below 50 beds for intensive care. So while we're up, obviously still far below the peak in the fall. In terms of COVID vaccine administration, we've now had almost 2,250,000 total vaccine doses administered to Minnesotans. This again is a combination of first and second doses. This represents almost 1,440,000 Minnesotans with at least one vaccine dose. 854,000 Minnesotans have had a complete series of the vaccinations. But just again want to remind folks that full immunity or full protection does not occur until 2 weeks after the last in the vaccination series, depending upon which vaccine you get. And with that, I'd like to turn it over to Dr. Linfield to talk about variants.
Thank you very much, Commissioner, and good afternoon. We provide updates in recent calls about the increasing spread of several newer variants of the virus that causes COVID-19. Today, we want to share some updated numbers that shed a bit more light on how prevalent these variants are becoming and why we are concerned about the risk of another spike in cases, even as we continue to make encouraging progress on vaccinations. Before I share this information, I want to remind everyone that the variant tracking efforts in Minnesota and across the country are not able to provide us a full picture because we can only analyze a small number of the overall COVID-19 cases out there. But we are working to expand this effort, and even with the partial picture we're able to get today, we can get a sense of the overall pattern of how prevalent these variants are becoming. Analyze a small number of the overall COVID-19 cases out there. But we are working to expand this effort, and even with the partial picture we're able to get today, we can get a sense of the overall pattern of how prevalent these variants are becoming. For mutation to happen. Most mutations can make a virus more transmissible and or more likely to cause severe illness. Right now, CDC also recently reclassified two variants, first identified in California, which are labeled B1427 and B1429 as variants of concern. This classification is an indication that there is growing evidence that these variants have potential to spread more easily, and they may be less responsive to prior immunity or vaccine-induced immunity and certain monoclonal therapies. So far, we have seen 108 cases of these two variants in Minnesota. It's interesting to note that only 8 of those cases reported travel, 7 within the U.S. to states such as Colorado, Wisconsin, Arizona, Florida, and Nevada, and 1 was an international traveler with travel to Mexico. We previously reported 2 cases of the P1 variant, originally linked to cases in Brazil. We have not identified any additional cases. As for the variant that was originally detected in South Africa, the B1351 variant, we detected a handful of cases previously and have identified 3 new cases in Minnesota for a total of 6 overall cases. All 6 reported travel to Africa or were exposed to someone who had recently traveled to Africa. The greatest spread in Minnesota right now seems to be with the B117 variant. This is the one first detected in the United Kingdom. We have now identified 479 cases of this variant. When we look at one of our partner labs who has been sending specimens for sequencing, we estimate that 50 to 65% of COVID positive specimens tested March 16th through March 20th were B117. This is an increase compared with specimens tested March 10th through the 15th, in which 38 to 44% of those specimens were estimated to be B117. Experts have predicted that B117 will be the predominant circulating strain in the US due to its higher transmissibility. It is interesting and concerning to note that only 15% of the identified B117 cases that provided a history on whether or not they traveled reported that they traveled in the 14 days prior to developing COVID. This indicates widespread transmission of the B117 variant within Minnesota. It should be kept in mind, again, that we are not identifying all cases of B117. However, among those that we have identified, approximately 5% have been hospitalized. We will monitor this closely as we expand our sequencing efforts and are able to identify more variant cases. At this point, it is a race to vaccinate more people versus the growth of variant cases. As encouraging as the vaccination numbers are, we need to remember that we have a state population of 5.6 million, and most Minnesotans are not yet fully vaccinated. That means we have millions of Minnesotans still susceptible to COVID-19 infection and the health impacts that can go with it. A more infectious virus spreading widely among millions of susceptible Minnesotans, some who may be tempted to relax their social distancing, masking, and other precautions, can help fuel a third spike in COVID cases and a corresponding increase in hospitalizations and deaths. That brings me to the final point I want to make. We know these variants are spreading, and we know how to slow them down. We have been at this for many months, and we're all excited to get to the end. But with these variants circulating, and with it being easier than ever for one infected person to pass COVID-19 to another susceptible person, now is the time to buckle down and finish the job we all started. Governor Walz and many people at the state and local level in Minnesota are working furiously to get as many people vaccinated as quickly as possible. And the rest of us need to give them time, the time needed to win this race by slowing the spread of COVID-19. That means being diligent about the straightforward practices we're all familiar with. Wearing masks when in public, observing social distancing guidelines, staying home when sick or exposed to someone with COVID-19, and getting tested when appropriate. At this point, I'm going to turn the conversation over to Infectious Disease Director, Chris Ersnet.
Of COVID. Dr. Linfield mentioned the importance of vaccines as a tool against COVID-19 and the continued importance of social distancing and other practices as a way to limit spread. I want to reinforce those comments and also share some additional points. It's truly remarkable that we have 3 highly effective vaccines available in growing numbers in just a bit more than a year after this disease was first identified. These vaccines are safe and effective, and they are our best bet for ending the pandemic and moving on to those brighter days we are all anticipating. Vaccines are important not only because they can offer really strong protection for an individual, but also because when enough people around us are vaccinated and protected, the virus simply can't spread effectively from person to person. This herd immunity threshold is something that's very important from a broad population health perspective for many reasons. One of those reasons is that the vaccines, while very, very effective, do not have a 100% effectiveness rate. In a small number of vaccinated people, their immune response isn't strong enough to the vaccine to completely prevent infection with the virus if they were to come across it. So far, we've been pleased to see a very small number of these so-called breakthrough cases. This is a situation in which someone who has been fully vaccinated and it has been at least 2 weeks after their last vaccination, and they still got infected with the virus that causes COVID. Of the more than 800,000 people who have been fully vaccinated in Minnesota, we've detected 89 breakthrough cases at this point. That's well below 0.1%, an incredibly small number of cases that dramatically illustrates how effective these vaccines are. It's important to know that even if someone is vaccinated and then goes on to be one of the few unfortunate people to develop a breakthrough case, there can still be some level of protection provided by the vaccine. This is reinforced by the fact that we've had 0 deaths among the 89 breakthrough cases to this point. So what's the takeaway message here? First, we should not be surprised by occasional reports of a breakthrough case. And second, we should not be fooled into seeing such a case as a reason to doubt the vaccine effectiveness. Remember, a 95% effective vaccine still means we could expect to see infections in around 5 of every 100 people who get the vaccine. To me, the other takeaway is that we should all eagerly anticipate the day when we have reached a level of vaccination that we enjoy herd immunity. And we talk often about 80% as our goal for that. And we'll continue to refine those numbers as we learn more about what's happening with COVID in the United States as well as in other countries. Once we reach that herd immunity, the virus will not be able to find the small number of people who remain susceptible, either because they didn't get vaccinated or because they didn't have a strong enough immune response to the vaccine. We're making encouraging progress towards herd immunity, but we're not there yet. And you can help us get there by getting the vaccine when you're eligible. And with that, I'll turn it back to Mike Schomer.
Thank you, Chris. Operator, we're ready to take questions.
Thank you, sir. As a reminder, if you would like to ask a question over the phone, simply press star, then the number 1 on your telephone keypad. Again, that would be star, then the number 1 on your telephone keypad. We have our first question from the line of Jeremy Olson from Star Tribune. Please go ahead.
Hi. One question I had was about, when it comes to this race, so the variants versus vaccine, one group of people who isn't in the race are kids, 16 and under. They can't get vaccine, and even if they wanted it. Do we know anything more about these variants from our experience in Minnesota about circulation among kids? Does it seem to be spreading more easily in the younger population than perhaps earlier versions of the virus did?
I think the short answer to that question, Jeremy, is yes. That we do have evidence of that. This is Jan, and I'll pass it to I don't know, Chris or Ruth, which of you would like to start? I'm sure you both have some perspective here.
Ruth can start.
Okay, thank you. We certainly get the sense that youth are what we might refer to as the leading edge of the spread of variants. We have documented, as we've discussed on media calls, the outbreaks that we are seeing associated with youth athletes as well as in the classroom and spread amongst daycares. We are seeing what we refer to as a higher attack rate. What we mean by that is the number of people who are exposed. When they're exposed to B117, more of them actually develop infection than a similar group that might have been exposed to a routine strain of SARS-CoV-2. And so we certainly are seeing it be more infectious than the prior strains, and that is something we are concerned about. And because of the importance that we really put on in-person education, we really, really need to rely on communities to do their best with these prevention measures so that we can decrease the spread amongst youth and keep them in the classroom.
And I'll just add, Jeremy, that not to focus on the variants, but just to acknowledge that the gap in having an available vaccine for persons 16 and under, is something that we're eagerly awaiting a change to. And both Pfizer and Moderna have been conducting vaccine trials, including kids down to age 12, and have also begun additional trials in younger ages. So we're looking forward to those results, and our hope is that by late 2021, or by the fall, that we would have vaccines that could be administered at least, if not to all children, at least to older children and adolescents. So that will be positive when that's available.
And a follow-up question, stick with me here. I was following a social media argument in my community in which someone was arguing against kids participating in preschool testing. Her logic was that broad testing would find more mild cases and result in more school lockdowns and more stress. Now, setting aside the question of whether testing is a good idea, my question is, does an increase in cases now mean the same thing as it did months ago in terms of our response? Or would lockdown measures be less likely because we've got so many people, vulnerable people, vaccinated? I guess I'm wondering if an increase in cases means the same thing as it did months ago.
That's a great question, Jeremy. This is Jan, and that certainly is what we're looking closely at. And we just frankly don't have enough information yet to be able to be really definitive about that. So far it appears that the percentage of cases that are resulting in hospitalizations in this recent upturn that we've seen, that's a similar pattern to what we've seen before. What we don't yet know, but what we hope and expect to see, frankly, is that the composition of those cases and those hospitalizations is changing, skewing towards younger people with milder illness. So as some of the most vulnerable are vaccinated, we hope to think we are seeing early signs, but hope to see more of this, that the proportion of cases that are in the ICU or that result in deaths is lower than in prior surges. But that's, again, we're looking at the Minnesota data, but we're also looking at other states that are perhaps a bit ahead of us on the case growth curve, as well as other countries. So there's frankly some mixed indicators out there, but we are hoping that certainly the vaccines will have an impact on, as you say, on the course that the increased cases take.
Thank you.
Thank you. Your next question is from Dave Orick from Pioneer Press. Your line is now open.
Thank you. Piggybacking a little bit about what Jeremy was asking, Dr. Linfield, can you drill down a little bit more when you say youth? Physiologically, there's a big difference between a 16-year-old and an 8-year-old. Do we have a big enough sample? And what can you say about the age groups being what you described as the leading edge of the B117?
Well, I can say, and we continue to follow this, it's not that, say, a 16-year-old may be more at risk for getting infected than an 8-year-old or than a 25-year-old. It's that currently we are seeing more interactions, such as what we observed in the Southwest Metro, where there has been spread amongst middle and high school students, but we've also seen spread in other areas. We've seen spread of B117 in a workplace. We've seen spread of B117 in a daycare. So it is a more contagious form of the virus, and that is well documented in many geographic areas. The reason why I said leading edge is because there was the opportunity for spread that we have seen documented, and we have seen it spread amongst younger people. Some of that may in fact be because they're not vaccinated, as Chris has described. And some of it just may be the sort of interactions that have been occurring over the past month.
Okay, thank you. And one last similar follow-up. You said among the B117s, there's a 5% of those that have been confirmed have been hospitalized. How does that compare to the wild strain, or can we not compare it because the sample level is too low and the data is too young?
Yes, thank you for asking that. Certainly, as we get more data, we will have a better sense. And we are expanding our sequencing. And because of the way we have asked for specimens for sequencing, it's a bit skewed. It's not a random sample. So when we see clusters, we have asked for specimens to sequence, in addition to doing some random samples, but it is skewed more heavily toward our trying to investigate what is going on. So we do have, overall, when we look at the B117 cases that we have identified, the median age is a little lower than the overall median age in the state. However, as I said, the proportion of specimens that ended up being B117 from a partner lab is really increasing rapidly. And so we do expect B117 to really dominate. It is already dominating. We will know more then when we look at our cases, and when we look at the identified cases, the hospitalization rate so far is similar, but the age of the person being hospitalized, the median age is a little bit lower. And as we get more data, we can be more definitive about that. Again, I want to be a little cautious because it's not a random sample of identified cases.
Thank you.
Thank you. Your next question is from Katharine Richard from Minnesota Public Radio. Please go ahead.
Thanks. So Dave kind of asked the question I wanted to ask, which is what I think I hear you saying is kids, the variant isn't necessarily more contagious to kids. It's more that they are being allowed to be in settings where it might be easier to spread this contagious virus. And I guess that raises the question for probably our audience. If we know that it's spreading among youth sports and we know that it can potentially spread quickly in daycare centers and schools, how does that factor into the thinking around having schools be open and allowing youth sports to continue?
This is Jan. I'll take a first pass at that, but certainly invite Chris and Ruth to chime in as well. You know, I think as both Dr. Linfield and Director Erisman have said, we're still in the early stages of understanding this. It does appear that the epidemiology of this is a little different, and that there appears to be perhaps a combination of more transmissibility among kids. We do think that there's some evidence of that from other countries, and the fact that they're in environments.
Welcome to the conferencing.
And the fact that they're in environments. And the fact that they're in environments